All right. Well, welcome. We are on week 5 already. It's amazing how quickly the time goes by. I was just telling, you all that I've already done my review for your exam next week. Try to get in here a little bit earlier. Come in on your phones. And then after you're done with your exam, you're going to sign off your phone. And then I'll tell you when you need to be back on your computers, and that will be your attendance. Okay. As long as you get back before the time I say. Usually we start class and the exam. I would tell you to come back at 4:20 Eastern time. So if you're back before that, then your attendance will be good. Usually after an exam, I will do either a PowerPoint or I will do a Kahoots. And what I'll do is, like I did last time, do one in one class and one in the other, so you get both of them. So you actually get all of the information, so you can go back and listen to them. Does anybody have any questions, comments, concerns, anything? I mean, I've met with a lot of students, about the exams. Again, I'm still available if you need to go over it. It was a difficult exam, and I'm not going to lie, it was. So if you pass the exam, you should pat yourself on the back. Remember, you don't need an A in everything you do. I wasn't that nurse who graduated nursing school with all A's. I became a good nurse because I wanted to be, and I had that carrying in me. So it's my higher level degrees. Yeah, I'm a 4.0 GPA, absolutely. But in my younger thing, I graduated with a C. And as I call it, C equals a nurse, doesn't it? So you don't have to go crazy getting those A's and beating yourself up. Do the best you can. You put in all the effort, you do your best job, and you'll be okay.
I have a question.
Yes.
Is there still going to be a lot of theories on the next test or no?
There are a couple.
Okay.
Okay. You'll see in the review as I go over them, and it's sort of telling you where to look at.
Okay. Thanks.
You're welcome. I mean, the theorists you're going to see in your HESI too. So it's something that's not going to go away. So week 5, we're going to do the sensory neurological conditions and musculoskeletal. Remember, there is a discussion question. I did send some reminders out last night. And also we're going to be doing quiz 3 when we're done today. So I'll be going over that stuff. You do have a HESI case study, compound fracture. And remember your NCLEX questions. So there's a bunch of stuff going on this week. Now, if something's going on in your life, you can't get it all done, just let me know before it's due. I'll say it again. Good communication with me. Sometimes I can hold stuff off. I mean, life shows up. I mean, I have some students here that I've spoke with that I've allowed them a late entry. Kids get sick, you get sick, family gets sick, all things happen. So as long as you're communicating with me before it is due, I can work with you. If it's already passed, I can't do anything. So let's hurry up and go ahead. Let's get our PowerPoint. It's a huge PowerPoint this week. So I'm going to try to just go over those key concepts within it so that you can get what you need from this. So here we go. Let's start out the sensory neurological conditions. And actually, we start up with otitis externa. Ever hear of the word swimmer's ear? This is that child who's always swimming, or they get water in the ear and then they have pain, and this really hurts. So the one thing about swimmer's ear is they'll put eardrops in it. And sometimes it has to do with there's things in there. So they'll need to sometimes flush it out, and then it's only topical. We don't take oral ones for this. I have seen things in ears like roaches, crayons, and backs of earrings in the ear canal. So sometimes that could be causing it. Otitis media, what is it? Otitis media is the middle ear canal, okay? Otitis externa is the outer external ear canal, okay? So external is just the ear canal. Otitis media is deep inside. It's in the middle ear. And what happens is it gets inflamed, mucus gets blocked in there, and it hurts like really badly. A lot of times children, because of these short little open airways between their nose and their eustachian tubes, they're short and they're wide. You're going to see the mucus from the nose go up into their ears, and it just presses on those eardrums. And that's what causes all of the pain that goes on with them. So with ear canals, what do you see? Well, infants can't tell you, but you're going to see them rolling and rubbing and maybe touching their ears. And there might be crying. You will see things like the child, if it progresses, multiple ear infections, hearing loss, or you're going to hear them speaking loud, or when you talk to them behind their back, they don't hear you. So something's going on, their ears are blocked. And that could actually be the beginning of an ear infection also. So one of the things I'll tell you is if you have a problem with speech, the first thing that we want to do is look at, can they hear? Okay, if you can hear, you're going to be okay. If you can't hear, your speech is going to be more garbled. So it's a big bulging eardrum, and what do? Well, the first line antibiotic that we like to do is amoxicillin, okay? It's the first line that we give to them, and it's usually 10 days, and we usually will follow up for the doctor to look to make sure it's gone. So the one thing is to make sure that they get the infection completely. Now, one of the things is, how do we tell our parents and our children how to take care of it? Well, number one, these kids do great. A couple of days antibiotics, all of their symptoms are gone. But to make sure that everything that they got is taken. I know some children don't like to take their medicines, right? They're like, fighting with you, etc. But to make sure that ear infection is gone and you're protecting their hearing, because chronic ear infections can cause hearing loss. So make sure they take the whole thing. Now, hearing impairments, as I said, number one, hearing impairments, sometimes the first clue is that speech. They're not going to be able to speak as clearly as they should. So if you have a child who's hearing impaired, you need to find some way that you can communicate with that child, and this child needs to find a way to communicate with you. We know that younger children, by the way they're acting, they're crying, or the grimacing and stuff, they can tell you they're in pain, or if they want something, they can point to their mouths, etc. But again, body language is what you need. Now, you get a child who's hearing impaired, and you need to literally sit down with that child and be eye to eye, okay? Because remember, a lot of times they can look at your lips and see what's going on, all right? So eye to eye, face to face, look at the child, let them look at you. You are going to talk in short sentences, and you are not going to sit there and try to yell and do exaggerating things because they just think it's a funny face. So this is the way that you would address a hearing impaired child. Now, strabismus. Strabismus is when your eyes are going and they're pointing and they're crossing. What it is they can't focus each eye to get to one point, okay? So this eye looks at this thing and this looks at that. So the only way that you'll see them being able to see good is they usually put a hand, the older kids, over an eye, and then they could see, and they actually then will have their depth perception, that missing objects they're reaching for. Because when their eyes don't work together, how are you going to grab? You can't see depth by that point. You'll see them tilting their head. And these kids might be dizzy. I mean, if you can't see and you're seeing two objects, you're going to be dizzy, get a headache. So strabismus, what do? Well, usually if it's one eye, that's going on with it, we're going to put a patch on the unaffected eye. When you have an eye that don't work, whether it's that or an amblyopia, another condition, there usually is a muscle in the eye that's creating all of this problem. So you patch the good eye and let that bad eye work. And you do it for periods of time, not the whole time, but periods of time. But usually with that patch, which is that eye exercise that you're going to do, and we put glasses on these kids and they do well. Surgery is done, but usually it's not needed if you patch the eye because it creates that eye, makes it want to work. Now, eye strain. These are kids maybe who like to be on their iPads and they like to be on their gamers or watch TV or, that thing. Sometimes that can create eye strain. What are you going to see? Well, you are going to see some inflammation, squinting. They're not going to be able to pay attention because their eye hurts and their head's going to hurt, so they're going to go somewhere else. This kid, maybe they can't see the board and they're squinting. That could be part of it too. So then, they're squinting to look at the board and they're looking at their papers and now, they're having problems. So when we're looking at these children, what are we going to do to try to help them prevent this eye strain and to help it feel better? Well, we're going to just look at them, see what's going on. And we're going to tell them to, try to prevent this eye strain. Maybe they need to sit up closer, or maybe they need to go get glasses. Maybe they need that, to be referred to a physician. Now, retinoblastoma, you see that little white eye, little flecks you see? It looks like if you go outside at night and there's a light on and you see a cat, a dog, a bear, or a deer in the backyard, and they turn towards the light and you see those white things. Well, that's exactly what this child will look with just a flashlight. And it is a malignant tumor of the retina. We call it cat's eye reflex, okay? That's because they go outside and that's what the cats look like, okay? Sometimes there's other things that you see with it. Sometimes there's loss of vision. Sometimes there is, the eyes don't work, or, sometimes it does hurt. So with these children, surgery is required. They have to remove the eye on them, okay? So what they usually do first is they'll do some radiation. And remember those little radiation little things that they put on there? You always leave them there. And sometimes they'll do that beam and they'll put that to try to shrink that tumor in that retina. Then they'll do some chemo, and then usually that eye is going to be combed out. And then these children are going to need a eye that is a false eye. I had a kid in high school who used to take his eye out and roll it around the desk, and then he would take and pop it back in to gross us all out. Well, I didn't know what that was back then, but I'm sure if I had you could go back in time, he probably had a retinoblastoma as a child. Now, if you ever see a sudden appearance of a fixed dilated pupil, this is a neurological emergency. That means there's pressure in the head. There's something wrong, and it's creating that symptom for you to look at. Okay, altered level of consciousness. I mean, when would you have an altered level of consciousness? Now, these children, when you see them, you can have an altered level of consciousness when their blood pressures go low. As simple as that. Kids can show you that. So that's one thing. If you have a child, you take a blood pressure, it's not within a normal range. I would say, is this kid awake, alert, or is he getting confused? So that'd be something that I would look at. Another thing, fevers. Your fever goes up, you do get a little bit delirious. Medications, of course, any sedatives, anti-epileptics, they just feel like their brains are numb, and causes that. And of course, after a seizure, that postictal state, have a big grand mal seizure, And usually afterwards, there is a period of time where they're just not with you at all. And any increase in intracranial pressure can cause it.
Can
So,
it, sorry,
yeah.
can it cause it if you have like a hit in the head, like if you fall, you hit your head, or in the terms of a car accident and the shake, that kind of stuff?
Listen, I've had many children come in, they slid into third base, their head hit the knee of the defender, and the kid was knocked out, came into the ER, and he was, 100 times. So was I safe? Did we win the game? And we tell them over and over and over again. And headaches and vomiting goes along with that too, with loss of consciousness due to a fall or an accident. But yes, excellent question. Thank you for having me describe that. Absolutely, absolutely. Have you ever fell down, bumped your head really hard, and you're just dazed, you're confused for a little bit. And if it gets worse, that's when you have that sign of there's a brain bleed going on. That's when you get to the hospital. All right, these are all of your cranial nerves here. So I know you've gone over them in your health assessment. They're here. We're just looking at them again. And remember, this all tells you neurologically, how is a child doing? So there's another way to look at it that you can remember. Oh, once one takes the anatomy final, a good vacation seems heavenly. I like the way you do these acronyms and you figure things out, because sometimes I can't remember them without these. And I graduated nursing school many, many, many years ago, and I still have acronyms in my brain that I still use. Ray's syndrome is usually that a parent has a kid who has an upper respiratory, a viral, some sort of illness, and they give aspirin. No kid should ever get aspirin, okay? It can cause Ray's syndrome. And Ray's syndrome is a real bad problem, and it affects the liver, and it is could have bleeding, etc. And it's extremely, extremely dangerous. I mean, we're trying to, with Ray's syndrome, because of this bleeding, etc., we want to make sure number one is always airway. Make sure we keep that head so that it doesn't get a lot of extra pressure, because it can cause that also. It can cause cerebral edema, increased intracranial pressure. It can cause altered level of consciousness, seizures, coma. This is from an aspirin. There is one condition in the cardiac world that they give aspirin to, but and it's monitored very closely by physicians, and it's only one, we don't give it at all. I remember an aspirin bottle in my medicine cabinet growing up. They didn't have acetaminophen by then. So never, ever give a kid aspirin. There's always something else. There is the acetaminophen and there is ibuprofen. And if you don't have either, nothing. Because remember, we don't need to medicate a fever. Why do we medicate a fever? How do you feel when you have a fever? You feel horrible. So you want to get the fever down. In children, once that fever comes down, they get up and they run around and they drink. And that's what you want them to do. That's the reason why to medicate. You're not going to get a seizure because your temperature is 104. It's very rare. The fever comes from when you take a 0 fever, in normal temp, and then very quickly, 20 minutes later, you have a fever. The rate of rise is so quick. That's when you have those febrile seizures. Now, what is meningitis? Well, what are meninges, right? The meninges cover the brain and the spinal column. And what happens is somehow they get infected. Now, I've seen 2 types, and they both literally present the same. Fever, headache, stiff neck, sensitivity to light. And then, of course, that level of consciousness goes down. I've seen viral, which, what do we do for that? Tylenol, Motrin, and just takes time. Bacterial is the one that needs IV antibiotics and watched very, very closely so that we can take care of these kids and get that fever down. Ever hear of nuchal rigidity? That's part of meningitis, where you push the neck and the legs come up because their head is so full of pain. It's the meninges, the lining of the brain is inflamed and it's irritating the brain, so it hurts a lot. So these you could also call it that Brudzinski when they move the head when the knee flex, or the Kernig's when you try to extend the legs and they still the head with it. So all of it's because of the spinal column and the brain and the meninges. So these are some of those things that I just talked about. Brudzinski is you try to pull up the knees and their heads come up with it. Or the Kernig's, you try to pull up those legs, and again, they don't want to do that. So how do we take care of meninges? Well, meningitis. Well, meningitis is infectious, if viral or bacterial, you still have to be very, very careful with working with it. Now, all children with meningitis, viral or bacterial, will be getting a spinal tap, which will look at the cerebral spinal fluid. And then according to what it says. Now, a bacterial meningitis has bacteria in it, white blood cells are in it. So when you look, if you ever assist with this, if you see it white and cloudy, that's bacterial. Viral will be clear because it's no bacteria in there. It's just a virus in there causing all of this irritation. So these children are going to be placed, these bacterial are going to be placed on droplet isolation, which means wear a mask because it's in the air. Also, because there's inflammation on the brain, you want to make sure that you take these kids and monitor their neurological statuses, our pupils, strength of their hands, strength of their legs, making sure they're okay. So, another thing that, in my career that I've seen, we do spinal taps, and I worked in the ER a long time. And when I was working in there and knew that a kid was possible meningitis, it comes out white. I want to see what it looks like in that laboratory. When you have a bacterial meningitis, you're going to have those white blood cells, like I said, but you also going to have elevated protein. But you will see these bacteria, they love sugar. So you have low blood sugars, cerebral spinal fluid sugars. So low sugar, high protein, and white cells, and it could be too numerous to count because it gets to be that much. So again, you've got a kid with the inflammation of the brain. You're going to watch those neurovascular status. You're going to I&O, of course, anything with the brain, you don't want to do fluid overload. And then, of course, you want a calm environment, the TV not too loud, maybe pulling the curtains for them, because that does help these children feel a lot better. Also, remember, these kids could have seizures, so make sure the side rails are up. And I would pad those side rails to make sure, in case they had a seizure, that they're really not going to hurt themselves. So seizures, I mean, what triggers them? Well, sometimes we don't know, right? But we do know if you are somewhere and you see those lights flashing, sometimes you go through a store and they've got the music session and you see these lights flashing, they don't like it. Sometimes on the TV they do. Or all of a sudden, somebody comes and scares them. You see this overhydration. Too much fluid on the brain, too much intake can cause those brains to seize. And we know the light does really bother them, and we don't want to have that light up there like that. So seizure, how do we diagnose these things? Well, it could be that simple febrile seizure. They go through the workup and they go, it's viral, okay, it's febrile. we're just going to watch them. And usually you'll have a couple, maybe only one. My grandson, my first grandson, had one febrile seizure, never again. And now he's old enough that he's grown out of them. But if they're having seizures more than once or twice or 3 times or 4 times in a year, you're going to say, oh, we need to check it out. So what they'll do is a CAT scan. They'll look at the brain. Well, then they want more specific, and they're going to do that MRI, which is a more specific X-ray. They can see it a lot more dimensional. And they'll do these 24-hour EEGs. Literally, you'll see these kids in the ICU having these things done, or even some infants, you'll see them in the ICU, and they take these things to the head, and you're going to see that machine running. I used to work night shift, so you would see it going. And then I would have these children away from the door that would close, because they could hear that door close and you would see those things spike, those little, movements there. So again, how do we treat these kids? Well, number one, it depends on what sort of seizure they're having. Are they having just focal? Are they having what? So they're going to need whatever medicine. And it depends on the age of the child too. One of the things they're finding out, I actually just watched an incredible documentary on diets and how it affects children with seizures. It was an autistic little girl with seizures, and they put her on this special diet and she improved greatly. This is something that's worked on a lot these days, trying to help these children. So children with seizures, what are we going to do for them? Well, number one is we're trying to make these children not feel like they're abnormal. We're going to try to get their seizures under enough control that they can be acting like kids. Having a kid and not letting them do things, can you imagine that? They feel like they're punished all the time. We don't want that. So these are just basic nursing responsibilities for a seizure. So number one, you have a kid that you think is going to have a seizure. Again, side rails up. Now, if you have a child who is having a seizure, you're going to make sure that you take everything out of the bed that could be anything sharp, if somebody put them in there that you don't know about. But let's say the kid is alert, awake, walks around. You don't want any sharp edges. Like sometimes there's sharp edges on, the beds or on the cribs. Make sure that it's covered. These kids need a medical ID bracelet. The older kids with the phones, sometimes you don't look at the phone right away. So having like a necklace or a bracelet, they're getting away from that today, but I still think it's a great thing. I'd want to know if my kid was out there and was found, that they knew immediately my kid had a seizure. Also, if a kid is doing something that could have a seizure that could cause them harm, like swimming, they need to have supervision. They can have a seizure and just go underneath and drown, and we don't want that. And of course, anything that's triggering a seizure, we want to try to avoid it, okay? And the other thing, the most important, is compliance. Many parents don't like seizure medicines because it makes the kids a little dopey. It makes them numb, and their affect goes down. But that they numb the nerves in the brain, basically. So make sure that, I know a lot of parents don't like it, and they want to decrease what they're given, but they need to have compliance. We have seen children that they skip these doses because of whatever reason, and then they have seizures. And with seizures, you always have that probability of lack of oxygen and then hypoxemia, and then it can cause brain damage. They're using botulism, believe it or not, for seizures today, and it helps. Levodopa, this is for cerebral palsy. Cerebral palsy, again, is something with the brain. It's causing, your body and your muscles not to function correctly. Usually due to prematurity or a hypoxic moment at birth or later on, can cause cerebral palsy. I have a little boy that I worked with when I was doing clinicals, and they gave him botulism. And oh my God, it did help relieve some of that spasticity. Ever see a kid with CP that wants to see you, and all of a sudden they put their hands up and they're like trying to get to you because, and their muscles are just so tense. It does help. Also, they are using that levodopa, carbidopa that they use for Parkinson. Parkinson, it has been used, and that's that athenoid thing, and that is that treatment of that difficult movements. Again, these kids need really good skin care. They need good mouth care because a lot of them are on these, seizure medicines also. They will be having, if they can, get them up, put braces on to help control those muscle spasms and sometimes surgery. Now, kids with CP, many of them are nonverbal. They can't express, right? So you need to establish a mode of communication. Now, my little guy that is I love this kid. I even go back and visit him, and I'm not doing clinicals there. Establish a communication. Now, this kid has a little iPad where he can let you know what he wants, and it's great that he can communicate. And they're actually teaching him. He's 7 years old. He's learned shapes. He's learned colors, letters, numbers. And this is a lot more than when I started my career as a nurse. We didn't do that. And now they do. So I think it's great. Then the kids that are not severe CP, you want to be able to get them locomotion. Whether it's in a wheelchair or whether a walker, braces, something, let them be able to get around. Children want to explore, and just because you have CP doesn't mean that you're not with it. I mean, my little Jonathan is nonverbal, but I know exactly what he wants. You need them to be social. This kid is in a daycare and he loves it when they have sing-along songs, and he'll try to clap and he'll smile and he'll just get so spazzed. And he is on all of those things. He's done botulism and levodopa. So he was a lot more spastic. And again, getting this kid to do as much for themselves as possible is very important. And it is not just nurses, it's speech therapy, occupational therapy, and physical therapy that we need to use. So basically what I've just said, intellectually impaired children have the same psychosocial need as all other children, but they can't express it. And they don't talk, or they're not going to respond the way other kids do. So your job is to try to help these children be able to express themselves, give them something that they're able, to express themselves. And you're going to see a really, really happy child, a happy kid who, even though they're nonverbal, they're CP and they can't move themselves around, but they are still very, very happy kids. So the importance of success is that the nurse has to help parents, because, these kids, whether they're in that prescribed daycare or if they're home, mom needs to take care of these kids and to, continue what we're doing, in that prescribed pediatric and extended care, which is those daycare for kids like this that have all of those speech and occupational physical therapy. So the one thing, with Jonathan, he can't talk, he can't eat. It's just part of what he is, but he's able to talk and be able to do shapes or whatnot. So again, you concentrate on their strengths, not on their weaknesses. Don't make them feel bad. If a kid is always trying to do something and can't, that kid's going to be angry and he ain't going to try to do it anymore. But if you're like, wow, you got that circle, that today, good job. Well, these kids will smile and they'll be so happy. And that's what you want. Again, each kid is different. There's all levels of CP. Jonathan was very severe, but you have some mild CP that, are in mainstream, working, as adults. So number one, when you have a kid with CP, is make sure that the family knows what's going on and to offer them support. They need to know how they can help their child be the best that they can be, how to adapt to their condition. And the child is in the hospital, again, routine helps. These kids know routine. These kids know what to expect when they're at home or and they're in their daycare. So try to keep it on the same thing as in the hospital. So again, disabled kids, whether they're CP or disabled and somehow, again, emphasize their strengths. Make sure we're talking with that family. When I was a teenager, I used to teach swimming. And they had a name for these children that today is very offensive. It was the American Association of Retarded Children. And that sort of tells you these kids are retarded. And let me tell you, they're not. They're smart. So I like the terms they use today. It makes me more comfortable, and probably working with these children, teaching them how to swim is one of the reasons why I love pediatrics so much, and one of the reasons, again, why I became a nurse. So don't put labels on these kids. They're not dumb. They're actually quite smart. They just can't express themselves. Make sure they get every experiences they need. Get them into the school, whether it's at 7-year-old just learning colors and shapes, that's still school for them. And then, of course, get the parents that support they need. There are many communities, local and state, and of course, national and internet communities that they can talk with each other. A lot of kids, they don't look like they're, disabled at all. And there are kids that you absolutely know that they are disabled. So when you're working with any kid, make sure that you know where their developmental level is. Don't assume that they're normal. Don't assume that they're not. Find out where they are developmentally, and then you can describe things to them. So a concussion that has amnesia, we were just talking about this, weren't we, is more serious than the presence of a fractured skull. Because concussion is that shaking, jarring, maybe you get hit by a car, your head goes coup to ka, and it goes back and forth, and it shakes and jars that head, and it creates a lot of pressure in the head. What do you see with these injuries? Well, as I said, you're going to see headaches and nausea, and it's going to progress into being dizzy, can't walk good, get sensitivity, and then it's going to get into, being not being able to awake, and it goes even further than that. When we have an injury, sometimes there's swelling because of brain bleed, right? Sometimes it bleeds into the brain. So when the brain bleeds, what's it doing? It's putting pressure on that brain. So that brain is not getting that area oxygen where it needs. And because of that, sometimes the flow of cerebrospinal fluid is interrupted, and then your intracranial pressures will go way up the roof. Now, shaken baby syndrome, this is, difficult thing to think about. These children have somebody who just shakes them, because I need you to be quiet. Can't you stop crying? I mean, sometimes this happens. Sometimes it could be due to, I've seen one case in my life, and it was a 3-month-old who the father was staying home with the child, the twins. And he took this kid, they wouldn't stop crying, and he banged his head on the shower sound, the shower wall, and created a brain bleed on these kids. And then we found other things going on with him. We got this kid good enough, soon enough. We got the kid and the twin safe. But this kid, you just touched his head and he was screaming. And that's the 3-month-old. Older kids, they're going to tell you. And they're going to be fussy, they're drowsy, or, maybe they can't see, so then they're not walking good, right? But headache, vomiting that's increasing is going to be what you're going to be so really, really concerned about. Now, sometimes when you are, get this increased intracranial pressure, you get these, what we call posturing. Let's say we have a kid who's had, fell off of a balcony onto his head. He's got this really bad head injury. You're going to see decorticate. That means hands come back to the core. And decerebrate, it goes outwards, okay? So these are the different posturings that you do see with children. I always like, which one is which? Well, decorticate is core, going back to my core. So again, how do you look for signs of increased intracranial pressure? Again, it's going to be that increasing vomiting, increasing headaches, change in level of consciousness. You might see there's some swelling around the eyes. Again, neurologically, you're going to see increased blood pressure, decreased pulse. Remember, you got your brain center, that controls everything, your heart rate, temperature, blood pressures, right? In the back of your head. It could have been with that. So again, check level of consciousness. Are they awake really? Look at their pupils, vital signs, and now seeing, are they moving? Are they okay? What do I need? Now, brain injured children can have very, very subtle changes. So you've really got to look for them. So of course, the younger kids are harder to check, but even infants, you'll see that restlessness. You'll see, something going on that, the kid doesn't act right, doesn't go to sleep right. The kid is crying a lot, irritable, not eating good. That might be an infant. Older kids, again, they might be, non-communicating, or they might show you headaches, or, hurting their head and touching their head and vomiting. So remember, it's hard to look for these things, but if a kid has fallen, you need to look really closely for any changes. So monitoring them. Well, sometimes kids go to sleep and you think you're just sleeping. Well, this could be beyond this. They can go to the point of being obtunded, means completely brain dead, not moving, even when you pinch, what we call nipple pinch. So making sure we wake these kids up and they know where they are. So pain stimulus response. And I'm telling you, the doctors love to do it. They'll pinch the nipples, whether it's a girl or a boy. Are they going to wake up? We're going to look at the cranial nerves. We're going to see if they're walking right. And of course, posturing, decerebrate, the corticate, of course, their pupils. Now, infants have fontanelles, that soft spot. Those soft spots really will tell you, is there swelling? You'll see that soft spot, the anterior will be getting a little bit bulgy on those smaller children. And the other thing is there's veins right in the front of their head, and they're going to bulge. As I said, that ataxia, of not being able to move properly on the older kids. And then, of course, that moral reflex, they're not going to really respond to those things. And, you'll see that, neck going up and down, and they're going to be pulling away from you. Now, drowning, you don't think drowning, could be once they're up and they're okay, right? Well, drowning is the 4th leading cause of death in children under 19. That's why we really need to have water safety classes for kids of all ages. I mean, honestly, I got a pool in my backyard, and I had a grandson who was living with me for the first 2.5 years. Well, by this age, this kid was age 2 and a little bit. This kid could do front flips in the pool. This kid was not wearing swimmies or armbands or nothing. This kid could have his head back, and he knew how to float. He knew how to get on his back, but he'll never go in that pool by myself, okay? Because I've seen drownings, and I have seen it happen to physicians that I know, and I know it happens. So what happens? Well, these kids go under and they get water into their lungs. So you have hypoxia, you have aspiration. pneumonia, and also if the pool is cooler, you have hypothermia. Well, unless it's 98 degrees, it's going to be hypothermia, right? Now, you can have things that happen up to 72 hours later. So these kids will be hospitalized. Many times rescue comes and somebody's pulled the kid out and somebody knew CPR and they spit out the water and they're okay. It doesn't mean they're okay. These kids have up to 72 hours and all of a sudden they'll stop breathing. So submersion for more than 10 minutes with failure to regain consciousness or within 24 hours is this kid has severe neurological deficits. And this kid basically is going to be brain dead. So when drowning is a big deal. So that's that chapter. 24. Let's start talking about kids, musculoskeletal, club feet. And, this little walker there, that's my cerebral palsy kid that he can walk on the walker with leg braces. It's a great motor device. So we have objectives to it. We'll just go past those and let's go into the musculoskeletal system. Now, children, their bones are not completely ossified, which means they don't crack. They bend more than they crack at younger children. One of the things about children, and we need to be careful about, is their epiphysis or their growth plates. It's the end of the bones. This is where those bones grow. That's how you get children growing. So if we don't have those, if there's a fracture there, we've got to be very, very careful of. Now, one of the things they talk about here is hyperemia. And hyperemia is when you have a lot of blood flow to different tissues. It could be trauma, right? You could call it a bruising, right? Could be cause those things. So we know that, muscles and bones, they're going to grow during, as they enter utero. And we know we use those things because we want to be able to walk and to use our hands, et cetera, et cetera. So as we are assessing our children, that infants can barely lift their head. That's the first thing they'll do. And then they get up to the point where they can walk, which is about 1 year of age. They should be able to take a couple steps. Whether they take a step and fall, they're trying to take a step. Okay? So we're looking at the way they're walking because we're looking at the muscle stones and tone. We're going to see what do those legs feel like. Is it straight? Is it bending? Their range of motion, like can you move your fingers around, your joints around, your hips around? And as we're looking at children walking, we are going to look at these children who are walking and they're older. Now, it's okay if a kid doesn't walk after, by 1 year. Some kids take a little time, but any kid who doesn't walk independently by 18 months of age is in a serious delay. And these kids need to be given some sort of care. Usually they put them in occupational and physical therapy. I mean, my children and my grandchildren never walked. They ran at 15 months. So that's okay because they were still trying and falling. But if they're not by 18 months, there's a problem. We know that skeletal growth, look at your infant. They grow 1 inch a month for the first 6 months. How quicker can you get of this growth? It does slow down, and then remember that pre-adolescent growth spurt, all of a sudden 20-25% of their growth is there. So grows a lot then. So I was talking about, these growth plates in these children. It's called an epiphyseal plate. And because these children's bones are growing so quickly, that epiphyseal plate needs to be, put in a place where it is in good alignment. Many times they'll put in pins and screws. They'll do surgeries to make sure that it's good so that they're straight and that each leg is the same height. And each arm is the same length because that's what happens. Now, toddlers begin to walk. They have this wide, like wobbly sort of gait. Now, their arms don't swing at this point. By 18 months, it starts to go in and they're walking more stable. And then by 4, they can hop on a foot, their arms swinging. And 6 years of age, the arms are swinging just like they are with an adult. So when there is a problem with motor, that, if they're not walking the way they should, and they're having, and they fall, whatever, as long as they're not hurting and they're moving, sometimes, these kids walk, that waddly gait. So let those parents know that this is normal. It's going to take care of itself. So we're sitting here and we're going to be looking at muscle tone with neurological, what's going on there. So we're going to look at the way the child moves their legs and moves their arms, right? We know that when we're looking at those things, part of that is neurological exam, right? It's, how do we, reflex palmar grasp, or are we having, that plantar regress? Do they startle when they hear noises, or their crib is bumped? I mean, all of these reflexes are part of the movement, the muscles. So muscles are a lot intertwined with neurological conditions. Now, when we have an issue, with bone, well, of course, you have a fractured bone, or you legs, club feet, we're going to, of course, do x-rays. We're going to do bone scans, or we could do MRIs and sometimes just a simple ultrasound. Now, sometimes we're going to see different type of things that go on with children. Could be they stepped on something and they've got, and her toe is inflamed and it's painful and they have a little fever. That's when they're going to do a CBC. Now, what will a CBC show when you have an infection? Anybody know?
Increased blood cells.
Absolutely. White cells are going to go up. Also, you're going to see their SED rate, ESR. Now, SED rate is, again, telling you the body is trying to fight some inflammation somewhere. So we always do them hand in hand so that we're showing, yes, something's happening there. Now, sometimes kids are complaining of their muscles and their bones and it hurts. And, what's wrong? Well, it could be a rheumatoid idiopathic arthritis, right? It's not rheumatoid. They call it juvenile idiopathic arthritis. And there are different types of blood tests that they take. Now, there's one here, human leukocyte antigen. It may diagnose it, it may not. They're developing new exams. Just to let you know, I mean, I have rheumatoid arthritis. It took them almost 10 years to diagnose it on me because they kept telling me you're fibromyalgia or whatever. So these are things that, we'll go and we'll look clinically. What does a kid look like, right? That's going to tell you. Now you have these bones, something's going on. Let's get some definitions here on treatments how do we take care of bones? Well, an arthroscopy is used to visualize, diagnose, and treat problems. When you think of arthroscopy, a lot of those are going to be knees, especially kids who are like to do sports, they can rip their, meniscus, those tendons in their knees, and they can do the repair just through a little scope, through a little hole going into the knee, and they can fix it. Now, bones. Sometimes you have bones that can get cancer. Osteosarcomas is in the femur bone. Sometimes it's very close to the knee. So they think it's a knee problem, but it could be that. So we can take a biopsy there. Traction. Now, traction is a great thing to use. I'll give you a story on a kid that came into my ER. Kid came in, his right thigh was swollen. He was out playing and he ran into something and he fell to the ground and complained of pain in his thigh. When I looked at him, it was swollen more than the other side. So immediately we got an x-ray on him and it was a fractured femur. Now the femur is one big solid bone, but when it fractures in half, you've got these two sharp edges that are going into muscles and going into nerves, and it hurts and it causes muscle spasms and painful. So right in the ER, we brought him down a real bed, put up Buck's traction, which pulled, and his skin, it's just like a ace bandage with like a boot that goes onto a weight, and it pulled that bone and it put the ends together. And what did that do? That stopped the muscle spasms and it stopped those bones from irritating those muscles and those nerves and decreased his pain. And he was so happy the pain is gone, finally, thank goodness. And then, of course, casting. Get a broken bone, what are we going to do? We're going to put a cast on it, arm or leg or whatever. And then sometimes it's a really bad sprain. Sometimes we just put a splint. Sometimes just fingers or toes, we might just put a splint. So we use all different things. Now, what are the principles of managing soft tissue injuries? Well, number one, when you first get, let's say you've had a sprain. I mean, I played volleyball in high school like crazy. I would spike the ball, come down, hit my foot, get crooked, and I would twist my ankle, and I could feel it rip. Well, I know I'm in pain. It hurts instantly. So first thing, rest. Get it elevated, get ice on it and put an ace bandage around it. And that's going to decrease the swelling and it's going to decrease the pain. So use this acronym, RICE, rest, ice, compression, elevate, okay? Up in the air, it does work. So it could be contusions, sprains, or strains. And again, immediately treated. I mean, I got to the point where I knew that I just put my foot right up in the air and they used to run to me with an ice bag and an ace bandage and get me done up and then get me sitting down on the sideline with my foot up because it hurts. And the longer you let it sit there, the more fluid that you're going to see inside of your ankle or knee or whatever it is. So, I mean, we want to prevent things, but you can't always. So just know how we can treat it. Cars, motor vehicles, safety, children. I mean, kids love to get into everything. Children are always, getting, running out behind cars, getting run over. I think that's the hardest thing for me to see. I've seen a couple in my career. I've seen kids do fine. They were ran over by a car and there's no injuries. And you're like, wow. And then I've seen kids run over by cars that didn't go home again. So again, prevention is just being careful. Now, car seats. Car seats, you're going to be in the rear. You're going to be rear facing until they're 2 years old. Or until they're 30 pounds, right? Then you can turn them around and put them in the rear seat, again, facing forward. They want you in the middle now. They think that in the middle is where they and if you look at everybody's cars, they're always on the sides, aren't they? They should actually be in the middle. They now want bicycle helmets on all the kids. Why? Kids fall, they bang their head. You're preventing, these traumas from going on. Pool fences, again, kids can get in your backyard and they can drown. Children getting out of windows. I mean, window bars, how are you going to get out in the case of a fire, right? So window bars can be a danger thing, but I'm not saying that you shouldn't lock them. I mean, my little girl used to, as about a year and a half old, she would climb up on the bed, open the dresser right next to her, and it was a jalousie window that you had to crank. It was an older house. she would take the clothes and she would throw them out. I'm like, oh, is it closeout day again? But could have gone out there. Now, conversely, my son climbed up on the dresser, opened it up, took the screen off, and climbed out the window. So being careful of those things, they will do it. Also, deadbolt your locks. Kids, I had them locks way up high because they try to go out the front door also. And remember, any sort of medicines have a lock on there because kids love putting things in their mouth, right? So make sure that we don't get any sort of overdoses because of them. Now, types of fractures. There's all different types, and they're all described in different ways, right? We know fractures, a kid's going to complain of what? They're going to complain of pain. It's going to hurt. I've broken only one bone in my career, and that was about 4 years ago, and it was my big toe. I fell down, I was clumsy, and it was a nice, good, right across the big toe. And let me tell you, it hurt. These kids that come in, it's going to be painful, tender, and they can't move it, and you're going to see some swelling. A lot of times you're going to see that ecchymotic area. They're not going to want to move it. And sometimes because of swelling, you're going to see numbness. So you got to worry about neurovascular signs, right? Now, children, what is great about them? You can have a fractured radius and ulnar at the beginning of summer, and you think their summer is gone. In 4 weeks, usually, those casts can come off. They heal very quickly. Infants, it's 2 weeks. It's very quick. So the younger the child, the quicker their bones heal. I think it's amazing. Now, you and me, it's going to take 8 weeks or more to heal a bone. Because why? Remember, it's more ossified, our bones. Those are more soft. They heal a lot better. Again, remember that we need to get those bones straight. They need to be casted, holding them in position so that they'll have good body, straight bodies and equal feet and arms. Now, some kids can get fractured femurs for many reasons. Could be from abuse, and it could be they fell off the bed or they climbed. What I tell you about toddlers, they're dive bomb kids, jump from the couch here to here, and they fell and they cracked their leg. Now, I've mentioned Buck's traction already, which is pulling it and getting those fractures together. But in younger children, this is what works the best. And it's called Bryant's traction, and it pulls them up in the air. Same principle as pulling them straight out on the bed, but it pulls it up, and it works good. Now, this child should weigh, the weight of the child should be less than 15 to 18 kilograms. That means it's not a bigger kid. That kid gets Bucks. The smaller kid is going to get that Bryant, and it's the whole leg they wrap up and they pull it. Their buttocks are slightly off the bed to hold it up, okay? And sometimes we'll put them in a restraint to try to keep those bodies straight also. So, care of a client in traction. Well, number one, remember you have a fractured bone, which could have caused swelling. There could be bleeding and ecchymosis. Check your neurovascular signs. Check them at least, twice a shift. You could see all of a sudden you see that numbness and swelling in the toes. And let me tell you, you need to make sure that you contact the doctor. Now, if you have a kid on traction, and some of them go home on traction, some of them stay in, but in a hospital, you want a firm mattress, and you want to, like, if the arms are not affected, you want to keep them strong. So a lot of times we'll put that trapeze on top so they can, do like monkey bars. They can, do exercises. They need that. Another thing is, remember, complications. They're on bed rest, right? They can't get out of bed. Traction is 24 hours a day. You never take it off. So preventing complications, the respiratory, wiggling in the toes, all right? Very important. course, we're going to give good nutrition because we need that. And whenever a kid is on traction, it's pulled and it's a rope that goes to a weight. That weight must be free hanging and you never ever take it off. Okay, because you're releasing traction. You could take that fractured femur and let those bones poke and hurt that child again. So let's do a couple little questions here. So Brian's traction, Volkmann's ischemia, is what? Compartment syndrome. Let me get those questions up. And I can send you these, also these answers to these questions for you so that you can have them. Hold on, I want to make sure I do this right for you. All right, I'll be sending that to you. I'll be sending you the answer to that one. Okay, Buck's traction. What did I tell you about that? That's a fractured femur, right? It is that ACE bandage with a boot, which pulls it. And again, it's the older kid, the bigger kid, and it pulls that hip and the leg, and it also helps that child be in less pain. The muscle spasms are less, and it helps the bone to start to heal. You know, years ago, we would keep them in bucks or even put a pin, a stymon pin, and they'd be there for a month. But today they're putting a rod through the femur, and it's what they do, and then they are on physical therapy. Make sure that the kid is up in the bed, that they're not sliding down because it will take the traction off. And they should be not placed with their head way high because it takes that pressure off. So their heads need to be down a little bit. So Russell traction. Russell traction is like Buck's, but slightly different. The leg is off the bed and you have an extra sling, okay? So you have two different pulls, holding the leg up and pulling it out. And this is used for different sort of fractures of the femur also. So, but there's two weights and two different points there. Skeletal traction is when you go into the bone, as in that stymon pin, it goes through. Now, Buck's traction, Russell's traction, these are all skin because we're putting something on the skin to pull. Skeletal is when we stick a pin like through the knee and that stymon pin, and that will pull it. Same rope, same weights, but it's pulled. Sometimes you'll see those halos around the neck. Sometimes you'll see those ones where it's around the outside, all different reasons for them. So again, when you're talking about traction apparatus, the weights are hanging freely. Don't let the child play with them because, and of course, if there are children visiting, to leave those things alone. And they don't want these pulling on them. And we want that bed to be up high enough so that it doesn't go to the floor. It has to pull all the time, 24 hours a day. And we know that kid can't be touching the end of the bed because then the traction's not working. This is an outside type of device. This could be a child who had a really bad break. And our concern is to keeping those pins that go inside the muscles in the bone to keep them clean, because they're open to the outside, right? So meticulous pin care, or these children will get osteomyelitis. Again, we're just talking about this problems with traction. You got, again, all of those things about, lungs and bowels and urine. I mean, these kids going to have to urinate in, a bedpan, a stool in a bedpan. And a lot of them, the older kids, just really don't want to do that. So instead of spirometry, and then of course, giving them a diet that will help them stool. So the body needs to be straight. The head of the bed can't be up, heels off the end of the bed. Of course, exercising the arms if it's the leg. The other leg needs an anti-embolic stockings on it. In fact, we'll try to put it on the injured leg too, but it's difficult because you might be jarring it. Neurovascular signs, like I said, is there swelling? Is there blood getting down there? And of course, skin integrity. They're on their butts. Maybe we need to, rub their butt, right? Because just because they're children doesn't mean they're not going to get any sort of sores. They do. So make sure we take care of their skin. And of course, pain. Make sure that they get the pain medicine that they need. Prevent constipation, like I said, diet, maybe even ordering something for it. And of course, using a trapeze. So these are signs of that you look at for neurovascular impairment. Pain, pulse, pallor, paresthesia, paralysis, which means, is it hurting and hurting while it's getting worse and worse? You tell these children, anyone who's gotten a cast, they go home and they have pain that's getting worse and worse. Okay, there's a problem. Then if there was an area where you could take a pulse and now you can't, or it's decreasing, again, that's another problem. Now, if you had nice pink fingers when the cast was put on and now it's getting pale, you're starting to get numb and you can't move it, this cast needs to be removed. These are things that we teach our child and our parent to make sure that it doesn't go like that. So you're going to check for tissue perfusion. Again, neurovascular signs, same thing. Check for pulse, check for the color, check for capillary refill. Is it cold? Is it warm? And can they move it? All of these things, very important as nurses we check. Again, it's just showing you where all the nerves are, et cetera, et cetera. So as I said, if you get that kid with that pain that's getting worse, the extreme, let's say it's a cast on the arm, it's getting pale, swollen, I can't move it, it's numb. It is called compartmental syndrome or compartment syndrome. That means no blood flow is getting there. That is an emergency. They need to cut that cast off and they need to put on another one. When you get a cast, they need to have that cast elevated for at least 24 hours after. And they need to wiggle their fingers and they need to be checking that pink finger get white and does it get pink again? Very, very important that we check those things. Again, cast care. You cannot have a wet cast. A wet cast is danger. It is mold that's going to grow inside of there. So making sure that they have their elevated, that they wiggle their fingers, and that they're, if they have a leg, that they're using crutches. If you've ever used crutches, they can be quite a chore. So making sure that they know how to use them, very important so they can get around. Now, we mentioned sort of a little bit about this osteomyelitis and something that can happen with bones. It doesn't matter, adult, children, whatever. When you see an infection of a bone, something's happened. There's been some sort of entry of a bacteria into the bone, and it's dangerous. It's going to require a long-term antibiotic. Now, the biggest common germ is staph. So staph is something that you'll be seeing in these children. So making sure that we are on antibiotics, and again, that they continue the whole thing. Many of them will place them on intravenous antibiotics, depending on the severity of it. Remember, any child who has a fracture and the bone is sticking out, a compound or open fracture, these children are at risk for osteomyelitis. So sometimes you can have, with a broken bone, you can have a thrombosis. You can have pulmonary embolus with these things. Remember that children, who have these big bones or these infections, it could be a toe, that got infected. One of my doctors, actually my personal doctor, son, stepped on something and his toe got osteomyelitis in it, and it got swollen, and it really was extremely painful. And remember, he couldn't even move his toe at that point. So again, infection, what do you see? Elevated white count, right? You're going to see elevated sed rate. You don't always see the swelling on an X-ray, but you're what you're seeing, your assessment and the labs are going to say, all right, yeah, this is a osteomyelitis. Again, trying to get it, that toe or that arm, whatever, moving can help, and it helps remove that infection, and of course, pain relief. And the one thing that we're always use with kids with any pain is a diversion. Now, diversion could be giving them, a game to play. It could be TV, music. I used to love for the newborns. I worked night shift. I'd turn music on. I'd have those premature infants, they would sleep with this music going on in my room. Plus, it kept me awake because I like the music. It could be coloring, whatever. If you're in pain and you give a diversion, it helps them not focus on the pain. Now, there is something called a Duchenne muscular dystrophy. Duchenne muscular dystrophy is a degenerative, progressive muscle degeneration where you have a child, usually a male, somewhere between, you'll see 2 to 6, 3 to 7, depending on which book you read. And the kid's doing okay, maybe a little bit slower cognitively. They usually are cognitively delayed. And all of a sudden, they're going to start not moving, even where they have that delayed motion. Okay, so all of a sudden, they're going to, get falling more, being more clumsy. I mean, as you start to walk, you're supposed to get more and more nimble and flexible and coordinated, right? These kids don't. They'll be falling. They also, because their muscles get so atrophied that they can't get up off the floor. Think about an old lady. What do? Like me. You get on the floor, and then how do you get up? You put your arms and you crawl up your legs to get you up off the floor and to stand up. Well, these young kids do that. You're going to see big, thick calf muscles happens. It's something else that you do see on them. So, and you're going to see sometimes what we call lordosis, which is a bending of the lower spine, but they are intellectually impaired. That's the only first sign that they do see. So we'll see, all sorts of things going on, but they'll do a muscle biopsy and they'll see the degeneration of them. And they'll do that myelogram and they'll look at it. And again, they're going to see how the motor is not functioning the way it should. So Duchenne or Becker's, remember Duchenne is the most common of all of them. It's usually their muscles are going away. Now, your heart's a muscle, right? And a diaphragm is literally a muscle that, helps you breathe. So you end up with death of cardiac failure, usually in your teenage years. It is, one of those things, it's passed on from mommy to the children. So we basically do supportive care. We try to keep those muscles moving. We try to keep them in functional position to be able to sit. These kids usually are a little overweight too. And we don't want them to get too heavy because then it's going to be hard for mom to move them around. And these children know that they can't do, and they're getting less and less they can, and you might see depression in them. Okay, so sometimes you have something called a slipped femoral capsular epiphysis. All of a sudden you have this part of your femur just skips and it moves. And what you're going to see is pain. And sometimes you could see this also with different conditions too, but the treatments are all the same. You have a problem with the hip that it's not right into place. You need to get that from this place back to where it should. So you're going to see a kid that is going to have pain in the leg, going to limp, and usually cannot put weight on the leg because that bone, that head, is not where it should be on these kids. A lot of times we'll just put them on Buck's traction and pull it out and give it a chance to get where it should go. Leg calf Perth is very similar. This is the other condition I was talking about. And basically the blood supply to the femoral head for no reason at all stops going there. And it's an aseptic infection, which means it's just that no blood is going there, so you have tissue death. It's usually in boys. And again, it's the head of the femur. So again, what do we do for this kid is Buck's traction and bed rest. And it usually will come back by itself, believe it or not. As I said, it heals usually spontaneously. Rarely do you see them need hip joint replacement. They're home, they take ibuprofen, and that's all they do for that. Now, we were mentioning about a bone tumor earlier, weren't we? The femur, and taking bone biopsies. Well, osteosarcoma is usually an older kid, ages 10 to 15. And these kids all of a sudden are going to have pain in their leg. Many times it's close to their knee. So it's pain, something's going on. So what they do is, it's limping and painful. They do an x-ray and they see this little bump on the femur. And they're going to start out doing these children radiation therapy. This is a highly aggressive cancer, and metastasis usually goes to the lungs. That's the first place it goes to. So osteosarcoma, we know that we got to worry about these kids for sure. And now I'm going to send you all of those questions. Manifestations, as I said, is pain. We do a biopsy. We're to do now. We've got a cancer on a femur bone. How are we going to remove that tumor off of a femur bone? We have to take all of the femur. We have to take the whole bone out. Now, sometimes after that amputation, this is going to be just like any amputation. They're going to feel that nerves and they're not there anymore. Now, what they're actually doing is today, they're taking the lower leg and attaching it up to where that femur is. And they're using what is called salvaging a limb. And they're using that to be able to have a place to put some sort of prosthesis. That's what they're doing today for these things. And it's working really well. As long as it's caught early, those kids do well, and then they get a prosthesis and they're mobile. Important. Now, Ewing sarcoma could be anywhere in a big bone. I've seen it in the scapula. You can see it in the jaw. Those are the two places I see a lot. Again, highly cancerous. It metastasized lungs and the long bones. And same treatment. It's going to be radiation chemotherapy. And if we get that bone out, we'll be okay. Sometimes you can't. Now, juvenile idiopathic arthritis, we sort of, mentioned an exam for it. As I said, there's so many different things out there, what works or what's really diagnostic or not. It's usually just your assessment that we can figure out what's going on. But JIA is very common in kids. You know, you don't think so, but it is. And it's all about the joints. Now, GIA attacks joints, and then you have lupus attacks organs. So these are two autoimmune type of diagnoses here. Now, what you see is a kid who gets up out of bed and is can't move in the morning and complaining of pain. And as they get moving during the day, they're a little better. Now, one thing about JIA, there's a couple different types of them, okay? So JIA, I mean, it's number one, how do we treat this? These kids are constantly in pain. Well, it's as simple as just giving them anti-inflammatories, giving them ibuprofen, right? It's one thing, you know, medicate the pain. These kids will end up on methotrexate, usually. Sometimes they're pills, sometimes they're injections, and that usually will help. And if it continues and they're not getting better, they'll put them on some sort of biologic, a DMARD it's called. You've heard of Humira, Enbrel, it's all over the TV. That's how you treat them. So that's usually the treatment for it. Now, they're systemic, polyarticular. So it depends. Is it in one place? Is it in just a couple places? Or is it just everywhere? So, I mean, it's still JIA. The treatments are still all the same. So systemic, here we go. Occurs most often in children ages 1 to 3 and 8 to 10. And you're going to see this fever for no reason every now and then, and it stays there. And you're like, why? Well, you're going to see this rash. It could be anywhere, and the tummy's going to hurt. Now, an ESR and a C-reactive protein both measure inflammation. Usually a white blood cell count, you're not going to see that elevated. If you do, it's severe sort of crisis that's going on or a flare. Now, these kids, you're going to see the SED rate off the roof and the C-reactive protein. I have inflammation absolutely everywhere. Now, polyarthritic is articular. It just means, you know, which joint, how many are involved. So polyarticular is 5 or more joints. Could be hands, could be feet, could be anywhere. And it's swollen, warm, and tender. And I can tell you, it does get warm, and it does get really tender, and it gets really stiff. You see this a lot in girls. It's usually 4 or fewer joints. It could be in the hips, the knees, the ankles, the elbows. It could be on one side, both sides. It's just, you know, very sporadic type thing. Again, sometimes we can get something, and this is why children and adults that have this arthritis, whether it's, you know, we call it juvenile idiopathic arthritis or juvenile rheumatoid arthritis, we call it in adults, they should have their eyes checked at least yearly. They get iridocolitis, which there's inflammation in the eye, and it can cause problems in the eye and vision disturbances, etc. So it should be looked at. So you have a kid who has juvenile idiopathic arthritis. They wake up in the morning and they hurt and they're in pain all the time. Well, number one, you want a kid to be a kid. So let them try to be a kid as much as they can. So how do we do that? Well, we're going to try to reduce that joint pain and swelling. We're going to give that NSAID, ibuprofen, maybe heat, cold. What do you like? Most children like heat. I love cold. So it depends on the person. Again, mobility, preserve joint function. Get that kid active. Let him swim. Let him play sports. I'm in the pool every day I possibly can. It's too cold right now, my water, or else I'd be in there. You know, that keeping that everything moving works well. Again, let them be a kid. Let them be independent. And just let that kid know, all right, you see him in the morning. So did you take your ibuprofen yet? Especially those older kids or that younger kid, mom making sure they have it for them, you know, and giving them breakfast before they eat it, right? We know that there are times when these kids feel great. There's times where these kids hurt. And let me tell you, sometimes you can't even like lift up your arm. Could be in your elbow, your shoulder. You can't turn over in bed. Just turning over hurts. So I really feel for these kids because I know exactly how it feels. So these kids, you're trying to get some sort of therapy that can control the pain for these children to allow them to be as normal as they possibly can. And remember, nurses are the ones that say, this kid doesn't look good. He doesn't feel good. He's not lying. I can tell this kid hurts. Let's try to change the treatment. Now, have you ever had a kink in your neck? One of these things you can't move and it hurts just to move. It's called torticollis. It's just basically your neck goes to the side for whatever reason. It is what we call a shortening of the sternocleidomastoid muscle. It's the muscle on your shoulder. It gets short, so your head pulls that way. Sometimes they're born with it. Well, look about how they come out of mom. They pull their head out, right? So you could hurt those muscles there. It can happen with breech or forceps, and sometimes you can see a torticollis, could be this congenital thing, and you might see it with other birth defects, like problems with their hips also. So their hips are crooked. So again, what happens if the infant holds the head to the side and you can feel this nice hard muscle in there? Usually it will go away. And how do we treat it? Well, we're going to try to stretch it. Range of motions, physical therapy, heat, cold, usually heat on younger children. So these infants actually, they will get better with it. And if the kid is hurting, of course, you only give Tylenol for the first 6 months, and then you could add your ibuprofen. Sometimes kids that are older are out playing sports, or, you've woke up and I slept on the pillow wrong. All of those things can cause it. Now let's look at those curvatures of those spines. Now, remember I talked to you about Duchenne, and it might have a curvature in the back. Well, that first one to the left is lordosis, lumbar spine, right? And then we have the humpback up top here. And then we have this S-shaped curvature, which is scoliosis. Scoliosis is sometimes poor posture. And you'll see the S-shaped curve. Now, if you notice, you'll see one shoulder up and the other one down. And sometimes you see even their hips, one's up and one down, because that spine is pulling them in a certain way. How do we treat these things? Well, usually we'll put them in a brace and we'll give them physical therapy, strengthen the muscles. And that's up to about 40 degrees, which means that curvature. Now, let me just explain why we want to treat this thing. Not only because you're crooked, but because that spine curving is going to impede a lung on one side. It's going to make it squat. There's not enough space in there because you're curved, okay? So we want to open it up so the lungs can breathe properly. That's usually why we do it. Greater than 40, we are going, and we've tried really hard. Brace, 23 hours a day, 1 hour off only for bathing, and then back on. And you put a t-shirt on underneath. So you have your t-shirt, then you have your brace, and you can put your other clothes on. Or we can go and do a spinal fusion. Okay, let's look at here, sports injuries. Well, kids like to get up, get out, and run, don't they? They like to play ball, they like to play soccer. In fact, right now, my grandson has just got done playing soccer. We put him in some sort of sports. Oh no, my God, does he love soccer? Kicking that ball. He goes, shoes in the air, because the kids would kick the ball and the shoes would be flying. So he comes home and saying, shoes in the air, another shoe in the air. And he was just giggling and laughing so hard. It's great for kids to do it. Great when you have some sort of person who's teaching it, who really works with kids well. But what happens? Well, you run into another kid, you get concussions, you injure your knees, you sprain your ankles. I actually in soccer had my one toe, the first joint got stuck up in the air. I kicked the girl so hard in her shin. And I guess I didn't have proper shoes on because they ordered them for me immediately so that it wouldn't happen again. You know, shin splints because you're doing too much exercise. It's just what happens. You play sports, something's going to happen. Now, what are the ones that are higher injury for risk? Well, gymnastics, because you're stretching yourself and doing repetitive actions. Wrestling, because you are working at someone and pulling and stretching. Football, soccer, of course, you're hitting each other. Hockey, again, banging each other with sticks. Basketball, that's aggressive. Well, volleyball, like I said, I've killed my ankles 100 times. And running is that shin splints. And of course, skiing, snowboarding. I have hurt my knee many a times just by skiing and snowboarding. So let's talk about family violence. You know, it's something that we don't like to talk about. You know, it's something that we wish didn't exist, but it happens. And I've seen several kids in my career abused. And these are kids I'll never forget because of the severe abuse that I did see. And I probably didn't see all of them, which that saddens me. We know that it affects children of all social classes. Doesn't mean the poor, the rich, anybody, any culture, it's across the board. It could be the spouse to the child. It could be neglect. And neglect is, you know, not housing, not food, not clothing. Those things are considered neglect. And then maltreatment. That kids, you know, always telling that they're stupid and they're bad, et cetera, et cetera. These are all things. Now, we know that when we have a child with abuse, there's usually a couple things why. Well, it could be that all of a sudden dad got unemployed and there's no money. So it could be a money problem. It could be something to do with drugs or abuse of that sort of in the house. It could be a parent who was abused as a child. That can also happen. And, you know, children, many different reasons why they get upset with them. They're disabled, they have to spend more time, they're angry because they have to do that. And let me tell you, it happens. Or they're hyperactive and all over the place and they can't handle them. Or they're not your kid, right? A foster child or a stepchild. There's all types of abuse. And let me tell you, the one thing about abuse, if you ever see abuse, you need to report it. The first thing that I did with that little 3-month-old baby whose head got hit in the shower, and I saw that fractured skull, and I knew it was abuse, is I went in, told the charge nurse, and I told the charge physician, I am suspecting child abuse. And we confirmed it, and we called in the authorities. Your job is to keep that kid safe. Number one, keep the kid safe. I wanted to beat up whoever was with that kid, but you know, that wouldn't do anything. My job was to keep that kid safe. Now we have emotional abuse. You know, they're always stupid. They're bad. They don't know what they're doing. Emotional, they don't give many hugs and kisses. And I've seen these things. Sexual abuse, I've seen it at all ages. You know, and it could be the cousin, the next door neighbor, the stepfather, the father, the mother, it could be anybody. Physical neglect, it means they're not fed. I saw one kid who was strapped to a bed and wasn't fed. The door was locked and wasn't fed. He came in and he was all bones. He was so much bones. His eyeballs were sunken in his head. And that was the most severe neglect of lack of giving food, okay? And then of course, physical, we know that can happen. So again, reporting it, make sure that you do tell somebody if you're suspecting it. You know, it's better to rule it out if you are don't know than it is just to let it go and it really was abuse, okay? Always know your state law. You know, we do have the Florida Nurses Act, and that's where it's set at. And it is any suspicion is you need to report it. So report it, we did. We got Child Protective Services there. They called in the cops because actually it was 2 children. We called in the other twin and he had the same things, and they need to get to that home and check it out. So healthcare workers we can call it in if we suspect anything. It's part of our job. Okay, nursing intervention. So how do you get this kid? He's 7 years old. This kid who they neglected to give him food. He came in, and I'm telling you, this kid, he had decubituses that smelled on his face from laying in one place for so long. Somehow this kid came in and he immediately coded, arrested. We did CPR on the kid. We got him back. This kid came back to see us a month later because I was working in the ER then. And he came back and he was awake and alert. Now, this kid had the most severe of any sort of physical abuse I could even imagine. I couldn't even imagine that happened. So now what do? Number one, this kid's got his name changed. This kid is somewhere else and nobody can see him from that family at all. He is, he's a ghost to them. So, but what about the kid? All right, we protected him from the abusers, but what about the child? Well, we need to protect that child. We need to make them feel better. We need to tell them how to manage these feelings about, what they're feeling. They need therapy, okay? They need to know how to figure things out and to feel good about themselves. And how do they cope with all this stuff, right? So assessing the child. Now, when you see a kid that you're seeing different sort of bruises and it's not matching the story that they came in with, this is one that you are going to look at. And here's this whole thing that you can look at, take your time. You're going to maybe a reddened genital area on girls, somebody was just sexually abusing them, bruises all over. I mean, this 3-month-old infant, let me tell you the list of injuries. He had a fractured skull, which the mom just saw something discolored here. Mom had nothing to do with this. Something discolored here, and it hurt the baby. So she brought the baby in. Okay. Then when we checked the child had a fractured humerus, fractured ribs, and a fractured femur, all different levels and stages of healing. Okay. So there was no explanation for any of that. So if you suspect, you start looking everywhere. We did an X-ray of the entire body is what we did. Knowing what stages are these children. This kid came in and his was looking more green. So he was almost a week out with this fractured skull at home. 1 to 2 days, swollen and tender, 0 to 5, red or purple, 5 to 7, green, 7 to 10, yellow, and then you're going to see it turn brown. Okay, these are what you see, different levels of healing, something you're going to need to know. So culturally and medical issues that we're going to see going on. Well, you need to be sensitive. Now, this mother had no clue, all right? It was the father, believe it or not. He had lost his job. Mom was working 4 or 5 different jobs trying to keep income into the house, and he couldn't handle it anymore. So it's all across cultures, all right? Sometimes cultural practices, though, can be perceived as physical abuse. Sometimes, like Vietnamese do something called cupping, where if they had pain in the back, they take a cup and they suck the back, and it looks like little red bruising things, but it's there for pain. Or they take pennies and they roll up and down. I mean, there's things that look like abuse that aren't. So again, if you see something that you're concerned, just say, so how did the kid get this? Oh, well, the kid had a backache because he had, whatever. And we did this thing. They'll tell you what was going on. So always, remember, sometimes culture is what it is. Again, if you are the nurse in charge of this child, make sure you document everything you see and anything a parent says, okay? And again, CPS or Child Protective Services are going to be the one that take care of all of that stuff. So that's a wild bunch of stuff that you learned today. I think I break it down and bring it closer together in your review. It's a lot of information there. Any questions by anybody? You know, I did have a Kahoots, but it's a quite long one. Let me see if I have a shorter one here. Give me 1 second and let me look, okay?
So you post the Kahoot in an
Oh,
announcement?
absolutely. You're going to get the Kahoots. That's
Great.
absolute. No, you will get it, but it's like 36. So
Do-
we won't do that.
Is there any one of them that is specific to the next test, or is it like all the chapters?
Okay, when we do the Kahoots, it's for the week that you're at, okay? So I will actually, I'm going to take and put your weeks 4 and 5 on your announcement where you have the recordings posted already. I want to do that for you so you have that. All right, let me see if I have another one here. You know something? Here's a 10-question ortho one, which I think would be an excellent thing. Let me look at it quickly. All right, let's go ahead and let's do this one. See, you have to have backup, don't you? You never know how long you're going to take, and I don't want to take the time away from you. So here we go, guys. There's your ID number. Only 10 questions, and then we're going to go into your quiz. I'm setting up your quiz right now, just making sure it's good. Do you believe it's the 10th of February already?
Going too fast.
It's amazing. I look at it like, where did it go already? We're already on week 5. You guys have learned a lot in just very short period of time. And there we go. All right, looks like everybody's there, ready to go. And let's do it. Just 10 questions. So ortho is a great one to do because there's so many things on ortho, and what do you do with that one? What intervention will a nurse caring for a child in Buck's skin traction implement? Remember, Buck's traction is pulling that leg for that fractured femur. We're pulling it apart so that the muscles aren't in spasm and those bones aren't sticking. So again, don't let that kid go back, to the end, so there's no traction. So you have to help them. There are weights attached to the legs, so you need to help them get up in bed, okay? What is normal capillary refill? Like you take and push the finger and it turns white. When should it turn pink? Three seconds is normal. 4, you're getting there. But you see 5 or 6, this kid, there's some delay in the blood flow. This needs to be reported to the doctor. What findings with the nurse assessing the neurovascular status of a child in Russell traction report immediately? Well, remember, Russell traction is just that extra piece underneath the femur area, and then the bucks traction on the bottom. It's 2 type of weights being pulled. What did I tell you? You should be checking for these tractions. So if we're seeing something's going on with the skin, now capillary refill of 3 is great. Skin's warm, that's great. They can wiggle their toes, there's no numbness. But bluish means there's no blood flow. Something's going on there that you need to report. Which observation would lead the nurse to consider child abuse when a child is evaluated falling down the stairs? So you're seeing red, green, and yellow bruises. And what does that mean? These are all injuries at different levels of healing, right? Because we know that red is, in the beginning, green is 5 days out, yellow's 10 days out. Something's going on. This kid has had injuries that mom's not talking about. So yes, very good, guys. What would the nurse consider an abnormal finding on a musculoskeletal assessment of a 4-year-old child? If you have a child walking on their toes, you have a neuro problem. There's something in the brain going on. 2 years ago, I had my daughter's fiance ask me to evaluate his best friend's little girl who was 4 years old. And she was walking on her toes. Well, I told him it seems like this child has something going on and also appears autistic. Well, because I mentioned that, they got the kid to the doctor, and now this child's getting intense physical occupational speech therapy, and this kid is doing so much better because of just the walking on the toes. Now, inward turn knees, this is, something that can be corrected, but it's not really an abnormal. Kids get all different, feet in, feet out, pigeon-toed, pigeon in, and it's something that, we can correct, but walking on toes is completely abnormal. What nursing action will significantly decrease the risk of serious complications for a child in that Bryant's traction? Remember, their legs are way up. So again, any traction, you have a bone that's fractured, there could be any sort of restriction in blood flow, neurovascular checks frequently, Q4 hours absolutely should be done. A child cares for a child in Buck's traction, which observation requires an immediate nursing intervention. Well, yeah, Buck's traction is trying to pull a leg. And if those heels are against the foot of the bed, there's no traction going on there. The kid needs help pulling them up in bed. Yes, it needs immediate, or you're going to get that pain in that area. Those muscle spasms are going to come back. A child with JRA or JIA has swollen knees and ankles, temperature of 38.8, and abdominal pain. What type of arthritis is this? And that's systemic. Excellent. Good job, guys. It's the fever. That was the hint. True or false? Bryant traction is reserved for children who weigh less than 30 pounds. So now in your mind, you've got to take the kilograms and convert it to pounds, right? And absolutely, it is true. Remember, you cannot put Bryant traction on kids that are bigger. It doesn't work. They have to go to Buck's traction. Okay? Does that make sense now? So Bryant's traction is their legs are pulled up. All right. And they're younger kids. And so you have to keep them in alignment. Sometimes you're going to put vests on them to hold them still. These kids that are bigger, it doesn't work. So they have to put them in just the Bucks. Or you're just pulling the leg. What should the nurse include in parent education about the long-term effects of leg calf purse disease? That's the aseptic hip thing, right? And it's, something that happens and the blood supply stops and you see pain, the kid's limping, and it's all of a sudden. So because they had this time of, no blood supply, remember, we treat it by Buck's traction and NSAIDs and rest, bed rest. But sometimes later on, because of this time where there was that no blood supply, it can cause arthritis. All right. Number 3, Alex. Good job, Alex. Number 2, Christina. Good job, Christina. Number 1, Tiona. Good job, Tiona. And then Sade and Chan. Good job. All right, let me get you out of here. I want you to go to your modules. If you've already tried, refresh. I've opened up the quiz for you. Any questions before we start? Remember, when you're done with the quiz, that you can leave. Again, anybody who needs to see me, make an appointment. I wish I could do it after class, but I got another class coming up very shortly. So just let me know. I'd love to go over your exams with you, okay?
Are we allowed to start? Sorry.
You may start your quizzes and you may leave when you're done. Thank you. Good job. See you next week. Bye.